Good afternoon, ladies and gentlemen. So welcome to this very exciting MitraClip Asian experience session. I'm an anchor person, Kentaro Hayashida, Tokyo, Japan, interventional cardiologist. And we also welcome Dr. Paul Sorager from US as a spokesman, very famous. And today, this is the collaborative session with the Chinese experience and Japanese experience. Actually, we Japanese or Chinese patient had really specific anatomy, so that's quite important to learn from the small body size anatomy, and it's also quite important to know the knowledge from our experience. So today, we're going to have the four distinct speakers. We also have the four very active discussants. So your question and the comments are most welcome. So please use the app to send your question and comments. So Paul, do you have any comment?
Yes, welcome everyone. Thank you.
Okay, great. Sure. Yeah. So I'd like to introduce the first speaker, Dr. Masanori Yamamoto from Toyohashi Heart Center, and he is the Chief Scientific Officer of our Ocean SHD family. That means he controls everything. And today his talk is about Ocean Mitral Registry. So Masa, please start.
Okay, thank you very much for the introduction. I'm very honored to be here. And here is my disclosure. So first of all, I'd like to introduce the Ocean Mitral Registry. It includes 24 centers in Japan, and the number of our family members are increasing year by year. And also the activity of the SHD interventions are drastically increasing year by year. And now our MitraClip experience is 4,000 up to 2023. So I'd like to share the data. And the evidence are also growing in the year by year. And ongoing multi-project is starting. And this is the acute result of MTER from Ocean Mitral Registry, the short-term outcome presented by Surgeon Mike. And the patient is including the 2,000 patients, and average and mean age is 80 years old, and the equivalent gender is 50% the female and the male, and high prevalence of the NYHA class 3 or 4. And unfortunately, at that timing, the introduction of the G4 is only penetrated in 28.7% patients in the entire cohort. And primary MR is 25%, and secondary MR is 74%. So that it's quite similar to the Western results. So this is acute procedure success rate. The 94.7% is early introduction in Japan, but relatively higher APS achievement in our cohort, and low rates of the 30-day mortality is 1.4%, mainly not related to the procedure. And here is the distribution of the primary and atrial and ventricular mitral regurgitation in terms of the APS. And relatively challenging situation in terms of the atrial mitral regurgitation to achieve the high rates of the APS. But in terms of the Western data, or comparing with the COAPT or CLASP 30-day results, the equivalent results of the 30-day acute procedure success rate can be achieved in our cohort. But of course, everybody knows we should pay attention for the complication and to achieve the acute procedure success, because the patient with moderate or severe MR or SLDA or TEER associated with a very high increased mortality after MTER. So worse prognosis of non-APS should be highlighted. But unfortunately, not to evaluate the predictive factor because of the limited number of the complications. So we need more data from Ocean Mitral Registry, upcoming Ocean Mitral Registry. So let's move on the one-year outcome of MTER from Mitral Registry data. And today's commentator was Shunsuke Kubo. And here is 1 year mortality after MTER. All-cause mortality is 12%, and death or heart failure hospitalization means MACE is 22.9% at 1 year. So it is very lower mortality rate Ocean Mitral comparing with the previous COAPT trial. The COAPT trial reaching the 20% of the 1 year mortality, reaching the 20%. And comparing with the TORAMI registry, the 1-year mortality is 20, and TVT registry also showing the relatively higher incidence of the 1-year mortality is 25.8%. So relatively a good achievement, introduction in the early experience of in our mitral field. So very surprisingly, not surprisingly, but the cutoff value of the acute procedure success means equal or less than moderate of the post-procedure mitral regurgitation. But post-procedure mitral regurgitation equal or more than moderate is associated with the increased risks of the 1-year mortality after MTER. So we should keep as much as possible to reduce the degree of mitral regurgitation after MTER in our cohort. So this is the impact of residual MR after MTER regarding of the MR etiology, as well as the primary MR, and the secondary MR also showing the very low grade of the post-procedural mitral regurgitation is associated with the improved risk of mortality. So that means that we keep less than mild or equal or mild, equal or less than mild mitral regurgitation after the procedure. It has our very strong message. So why is the worsening of MR during follow-up period? For example, this is my case. After the procedure, the degenerative MR, the mitral clip is successfully completely achieved less than mild. However, at 1 year, of course, many operator has similar experience of the worsening of MR. And please look, the distribution of the moderate MR from 1 month to 1 year is a little bit increasing rates of the MR worsening. So we want to keep to maintain the MR grade as much as possible lower until 1 year and 5 year and lifelong. So what kind of the optimal management? And what optimal management should be required based on the risk-benefit balance of the MTER and post-procedural MR severity, keep not moderate, less than mild or equal mild, okay? And but the situation is very difficult. For example, such kind of emergent MTER using mitral clip for the acute MI with acute mitral regurgitation with papillary muscle rupture. So technically, it's possible, And I did this such kind of very challenging situation, but in using the IAVP supporting and MR decreasing, and post-procedural PV flow drastically improving, and successful results can be performed for such kind of very challenging situation. But mitral clip can save the patient. However, the risk stratification is so important. For example, in the TAVR field, too sick patients is too late. For our Ocean TAVI registry data, such kind of the very frail patients, for example, the severely frail, very severely frail, or terminally ill patients, very high rates of the increased risk of mortality on 1 year is up to 44%, even after successful TAVI. And what about the mitral field? It's completely same. If we treat the 2 frail patients using mitral clip procedure, it's still very high increased risk of the MACE and all-cause mortality. So we should pay attention for the patient screening, and risk stratification is so important, I think. So anyway, so future perspective is many ongoing projects from Ocean Mitral, and we'll do the 36 station Peter is coming, and we need a collaboration with Eastern, Asian, and Western data. Thank you for your kind attention.
So thank you very much, Masa, for your comprehensive picture of the Ocean SG family. You also demonstrated our initial experience of the MitraClip in Japan, and we're quite happy with to see the collaboration with Paul. So Paul, do you have any comment?
No, sorry, is this working? Yes. Okay, thank you. No, congratulations on the registry and the outcomes. It's really quite amazing, the results that you've achieved with really early experience. I mean, we all know that the procedure can be complex. There can be some learning curve, and you basically achieve these results with no learning curve. So it's really quite impressive. I wanted to ask you about your frailty aspects. So it's very clear that the frailty is associated with worse outcomes. So how do you decide when not to do a procedure?
Yeah, very.
Because some patients, despite how frail they are,
Yeah.
just as you've offered and done these procedures, we still offer as palliation and
Yeah.
such. How do you decide?
Yeah, but still, among the frail patients received the successful MitraClip procedure is associated to the better outcome comparing the frail patient. So if we try to do the MitraClip procedure for frail patient, we should keep the acute procedure success, because patient with MR achieving less than mild is improved outcome for in such kind of the very frail patients. So frail itself is not a contraindication, but of course we should consider beyond the frailty. But I think procedural safety and procedural success is mandatory, and as a next step, patient screening is important.
Okay. So any questions or maybe Chinese friends?
Excellent result from the ocean trail. And just one question. We have noticed that from the results, we use the device's choice, the more NT and NTW. From the 600 patients, maybe use the nearly 300 NTW and the 261 NT. So the reason that you choose the more NT or NTW is based on the such as small anatomy, the Japan patient, or any other factors.
Yeah, unfortunately, at that time, the introduction of the G4 generation is only 23%. And because of some Japanese very strict regulation, first 8 cases should be treated by NT only. That is the reason why we have no choice. So if we adapt to the 306 patients, we have a lot of choice, and we can discuss more deep. But at this moment, it's very difficult to discuss about the device, types of the device, unfortunately. Yeah.
Thank you.
So congratulations. As I want to just echo what Paul said. That's really remarkable for your first attempts. I mean, I don't think we can say the same for our first attempts. We learned a lot. I was wondering if you could comment. There seemed to be a slightly greater return of MR than we might expect. I wonder if there's some unique technical challenges or issues in your patient population that might have predisposed you to that?
So
sorry, I didn't mean to ask that hard a question.
Yeah.
Basically, do you feel like you have different? I mean, Paul, you've seen over there different technical challenges in a different sort of size and anatomy.
Yeah, please comment on that. It's okay. Yeah, of course, device improvement. We should adapt the optimal device selection or some upcoming new devices. But please comment on that. Yeah.
I mean, I guess one thing is that the survival is better. So if these patients are surviving better, creating more opportunity for recurrent MR to manifest itself, that could be one issue. But in terms of the techniques, I don't think there's anything too technically different.
One of the things I think they've shown us is I've seen the data on the height of the transseptal, and you guys have been quite effective even when you're not that high. So you've demonstrated some real flexibility of the system to be able to do that. So thank you for that contribution.
Okay.
Actually, the Japanese patient had much longer life expectancy. That could be one of the reasons for the higher incidence of recurrent MR. And because we Asians have the very small anatomy, and the septal puncture height is sometimes quite low. However, we can use the ANOP to achieve some higher distance, so it will enable us to perform MitraClip procedure.
In the U.S. data, the rate of repeat intervention is 5 to 7% per year. So naturally, if one is living longer, there's going to be more opportunity for recurrent MR to manifest itself. So.
And now we're preparing 3,600 cases, but of course, it's much smaller than that of the TBT or something. So, do you think is quite hopeful for us to publish some data from a registry? Oh, that's great.
Sure.
Okay. So, thank you very much for your nice presentation.
Thank you. Our next speaker is Dr. Chi, mitral TEER in the clinical outcome and update in the Chinese population.
Thank you, Paul. So my topic is mitral TEER clinical update in Chinese population. I have no disclosure. Until April 2024, 186 hospitals in 28 provinces in China have performed more than 2,000 MitraClip operations. The short review of the TEER application history in China and in Fuwai Hospital. 2021, January 6, we started the MitraClip G3 debut in China, in our hospital. And April 17th, 2021, we did the first MitraClip by SOAR TEE guidance live case in China. And 2022, 100 cases in single center in the Fuwai Hospital. And 2023, June 16th, 1,000 cases of MitraClip G3 in China. And this year, 2024, April 22, the MitraClip G4 debut in China. I do appreciate our Japanese colleagues, the Ocean study. It's very good result. But in China, we didn't have this kind of registry study. We just have a rough data of the 2,000 cases. So you can see the etiological classifications. The DMR is 603, and FMR is 491, and the mixed cases 100. And the number of clips used during the operation, we can see that the 58% is one clip, and 40% two clips, and 2% three clips. And the types of the clips used is 63 are XTR, and the last is 37 NTR. In our team, we do the SOAR TEE guidance MitraClip procedure routinely. So we did some researches about the comparison with the conventional method. So this paper, the objective is to investigate the safety and efficacy of operating TEER under the transesophageal echocardiographic guidance solely, as the 10 patients enrolled, and so we can see that there is no significant difference between the conventional method and the new method. So, and also the other papers, the relevant parameters of 24 patients received the TEER between the control group, which is under guidance of traditional interventional with X3 plus echocardiography guidance and the SOAR TEE guidance. Yeah, that's the result. There is no significant difference. So the conclusion, compared with the control group, TEER under SOAR echocardiography guidance has similar clinical effects with traditional ways in terms of the parameters of mitral valvuloplasty and clamp quality. So let me show you the TEER by SOAR TEE guidance. Oh, this is Dr. Masano, KK Yao, and Korea. Last year, they went to our OR and they experienced the pure TEE guided MitraClip case. The basic methodology of the SOAR echo guidance technique, the working length A, working length B, the working length A from the puncture site to the right third intercostal space. The working length B, the depth of the lesion site was accurately measured by inserting a catheter according to the working length A and mark the depth of the catheter insertion. This is the general steps. Yeah, the puncture height are the same as the conventional method. Yeah, the difference is we don't use fluoroscopy. So how about the straddling? Yeah, it's easy. You can use a ruler during the operation to measure the straddle length. So it's about 3 centimeters for G3 system. For G4, it's 2.5 centimeters. Yeah, all these are the same as the TEER guidance. Yeah, so how about not every patient have a very good view in TEE? So how about that patients? For example, these patients, because she got the severe esophageal stenosis by cancer, and this is our strategy is to do the TEER on the sore transthoracic guided MitraClip. So this is a pre-operation evaluation. So for the puncture post-positioning, the 3 important view, subthyroid, 4-chamber, and short axis. So sometimes, because of the learning curve, we recommend to use the soft.
We cannot see anything
Sorry.
just now, but with the help of the top. If I retract the top of the caster, now we cannot fly, even
Okay.
if the caster.
So we use a special designed spindle tip of the echo guide wire. Is helpful for positioning.
So we touch
Because in our team, we do the atrial septal defect closure by echo routinely. So we use general wire or this special designed wire. So for the puncture, this is a short axis view. In the short axis view, we did the puncture process. So this is the SGC cross the septum. Then the CDS. So in the 4-chamber view, we turn the M knot, so you can see the CDS turn around. So it's like a cartoon effect.
过程当
Sorry. So right now we adjust the M knot. The CDS will forward to the mitral annulus. So that's clear.
过程当中，因为所谓的什么弹道啊什么的，
And also how
就
if we do
清
the
楚啊，它要垂直于这个
if we do the trajectory in the 2-chamber view, it's
能
clearly.
够在海里面自由游泳的时候，你就会发现。
So right now we do the grasping. So how about the orientation? Yeah, short axis view of LV. It's similar to the 3D emphasis view. But the difference is the adjustment is on the contrary to the TDE guidance. So we do the grasping under the LV long axis view. Yeah, it's a long LV long axis view, and we evaluate by the X-plane. That's the final. And also in the long axis view, we measure the the leaflet length we grasped. That's a final evaluation. But sometimes, how about if TEE and the TTE is also not good, so we can combine it together. For this case, this is a surgery of esophageal cancer 13 years ago. So there is a poor TEE image. So firstly, we do the TEE guidance. The septum puncture by TEE guidance, and wire advanced into the LV-PV, and SGC crossed septums, and we do orientation by TEE. Then after that, the echo doctors hard to find a very good view of TEE. So we do interactive TEE plus TTE guidance, so to grasp the leaflets after the adjustment. Thank you.
It's outstanding. So what compelled you to do no-fluoro? Is it just fear of radiation, or what compelled you to pursue echo only?
Yeah, I think two reasons. First one, we don't like fluoro. Yeah, first.
Clearly.
Yeah. The second one, because our team, we have done many years pure echo-guided the procedure for ASD closure, VSD closure, and PDA closure. We are very familiar with echo, and our doctors, they like echo. Yeah.
Was the patient who had the transthoracic only, was that patient awake?
Yeah, for the ASD, VSD closure, and the PDA closure, we do the transthoracic echo solely.
Yeah, and were they awake with conscious sedation?
Yes.
Awake.
Yeah, but for MitraClip, no.
No, not for much.
Yeah. Oh, well, okay. I should explain. For that case, TTE case, it is a consultation. Yeah, conscious.
Dr. Shi's great presentation and great job by Dr. Pan's team. In China or in Japan, so many people, so many T guys transform PCI guys. So as a cardiologist, no doctors want his patients sent to the surgery. So we have no chance. So we have only chance to do these operations success. So if we want to learn to the pure guys, what's the learning curve you suggest, and what's the take-home message and tips you tell me us?
Yeah. Yes. I think there must be a learning curve. Yeah. So I think we recommend to use the special designed wire. Just now I show you the spindle-shaped soft to cross the septum. Yeah. So this wire can be used anywhere for ASD closure, for PDA closure, echo-guided case. So, but in our team, if we use general wire, it is okay. Yeah. I think you may do it step by step. Yeah. To do ASD closure, the first step to familiar with echo images. Yeah. And so you mean the tips. I think the very good cooperation with the echo doctors. Yeah, I asked him to show me somewhere, not just the general view. Maybe sometimes he have to turn the probe to get a very good view for me. Yeah.
I have two questions. So I'm so impressed that he only guided the procedure. So the which place do you perform the procedure? So cath lab or just operating room?
Pardon?
The which place?
Which
where
place?
Where do you perform?
Where do you do the
cath lab
procedures?
or?
Oh yeah, I see.
And you're a surgeon, right?
Yeah. Firstly, we did this case in the hybrid OR, but later we just moved it to the general OR.
Oh really?
Yeah.
And how about the procedure time? So
Hybrid.
procedure time.
Procedure time.
Yes.
I think you see the researches there's no significant difference.
Right. So about 1 or 2 hours.
How long did the procedure take?
It depends on.
Oh, depends on.
Depends on. Yeah.
Okay.
Well, thank you very much. Congratulations.
Thank you.
I have the pleasure of introducing our next speaker, Dr. Mike Saji, an interventionalist, who's going to be speaking to us with an interesting case, small valve area and low height.
All right. Thank you, Dr. Suraja. My name is Mike Saji, Toho University Faculty of Medicine, Tokyo. I'm going to talk about the challenging anatomy with a small MBA and inadequate transseptal height. Disclosure. So the 91-year-old lady with a severe primary MAR was referred to our center for TEER. NYHA functional class was 3, and the past medical history include a cabbage, a PCI, diabetes, hypertension, and CKD. She was considered prohibited risk for open heart surgery because of the high ST score, advanced age, and mild frailty. So the patient was sent to the TEER. So this patient has a very small, the 145 centimeter tall and weighs 48 kilo. This is a very typical Asian population. So the transthoracic echo show the thickened anterior leaflet with the calcium on the part of the leaflet and the annulus. And as you can see on the right side of the screen, there's a 3% MAR from A2P2 area with the preserved ejection fraction. And we can recognize that on TEE, that the slight restricted motion of the anterior leaflet and the MAC on the posterior medial side of the annulus, as you can see on the left side screen. And the TEE also show the transmitral gradient of 1 and mitral valve area of 2.6, which is very small in the TEE patient, TER patient, measured by 3D measurement. So the 91-year-old, a very small lady with a mild frailty, has a symptomatic severe primary MAR. MR jet come from A2P2 area, and echo shows the small MBA, and on the hemodynamic measurement, that it was a low cardiac output. And the echo also showed the degenerative leaflet and the mean gradient of 1. Posterior leaflet length of 8.3 millimeter and computational length 3.3 millimeter. And you can see on the MAC on the posterior medial side of the annulus, and she was on sinus rhythm. So by the heart team approach, a decision was made to do the TEER with the NTW on a slightly lateral side of the P2 to avoid MAC. So the transseptal puncture site was just a 35 millimeter, which is challenging, but acceptable in this population, I think. And the target site was just next to the posterior MAC, as I presented on the right side screen. And clip was positioned using the A-knob and extra M-knob because of the low transseptal height. And there was no room for going back to the left atrium, so it's just a single ticket. And finally, we had a trace MR. However, the gradient significantly increased from 1 to 5 millimeter mercury. So the current situation, the trace MR with a transmitral gradient of 5, the impact of transmitral gradient after TEER remains unclear. It really depends on the output, heart rate, and the residual MR. And the MR reduction may be prioritized than the iatrogenic mitral stenosis, in my sense. And what we can do during the procedure are putting the pigtail in the left ventricle and have an invasive hemodynamics or for possible TE overestimation. And if the heart rate is more than 70, beta blocker can be used for lower transmitral gradient. And we can reposition the NTW or grasp less for a lower transmitral gradient. Or of course, we can change the device from NTW to NT and accept residual MR, but it's a trade-off relationship. And finally, transmitral gradient may not be higher in her daily life because of a very old, mild frail patient. So the TTE on the next day of the procedure show the trace MR without significant mitral stenosis, which is 4.6 millimeter mercury, and a short discharge with a significant decrease in NT-proBNP level from 7,000 to 1,000. So in addition to unclear impact of transmitral gradient, it's not easy to accurately measure the mitral valve area technically. Impact of small mitral valve area in patients with a small body size may be different from those with a normal body size. So in conclusion, strategy, the types, location, and number of clips is a key for success TEER in patients with a small MVA. Impact of residual mitral stenosis after TEER and the approach to measure mitral valve area are complicated. All cases need to be well discussed by the experienced heart team. Thank you.
So thank you very much, Mike, for the demonstrating very exciting case. Actually, we Japanese had really small body size patient. However, this patient really small mitral valve area to be 2.5, and she also had the severe MAC. Mm-hmm. So, any comment from the panel? So maybe Masaki, your echocardiographer.
Thank you very much for your great presentation. And, congratulations on your great success. So, this patient has small mitral valve area and MAC and degenerative leaflet. So this is a very high risk of mitral stenosis after mitral TEER. So why did you choose the NTW? When we, I think we will choose the NT. Why did you choose?
Thank you very much. So we also concerned that mitral stenosis after the procedure, but when you look at the transmitral gradient before the procedure was just one, and also we recognize that the patient is very small, and also she has a small cardiac output, so probably NTW is acceptable for a patient. But if we have very high gradient, we have to change that to NT device.
W is a really good option in this patient because MR jet is wide.
Correct. Yeah. So before the procedure, we have a very wide jet, so NTW is
reduction of MR and mitral stenosis is a really trade-off in this procedure.
I certainly think that a W is better than two NTs.
That's right.
Right, in this case. Two NTs would have been a no-go. One other thing that one can do for these gradients is that you can actually open the arms up to 30 degrees, and that can relieve the gradient.
That's
and
right.
if it doesn't change the MR, you can leave it at 30 degrees, and it actually works very well.
That's
so
right.
I've done that in a number of cases.
That's right. So I never tried that clip open up 30 and release it. Almost I close it, but not too tight, and release it. That's my plan.
So, Paul, you have huge experience. So, if we open up to 30 degrees, does it cause to the SLDA or
it's safe.
Okay, that's great.
It's very safe. You test the FAA all the same. You do the FAA test twice, and it's totally safe. And so, when the gradients have been 6, 7, in that range, I try to open. I go to the BICOM with color and just see if the MR returns. And if it returns, then you have to decide, okay, too high of gradient or residual MR. But this case was excellent. I would have done exactly what you did. It was perfect.
Yeah. And choosing between the residual MR and increase of the pressure gradient is also a very important topic of this case. Right. And suppose, which do you prioritize?
So it's interesting. So I first look at the LA pressure. If the LA pressure has gone up significantly, then I tend to go with the MR. Because if a gradient is associated with increase in LA pressure, I don't think that's really good for the patient. MR is easier to treat. But to Mike's point about the gradients and the data, it's really mixed. And it looks like it's much more associative than it is determinate. And so I would tolerate gradients 5 to 7 in a lot of my patients if I can get rid of the MR.
Yeah, we also take into account the patient condition. This case is 91 years old female. That's right. So reduction of MR and is okay, is good. So we can also leave some residual gradient.
That's right.
She could tolerate.
Yeah, when you look at the co-op data, most patients are very sick. So that's why there's no difference between the high gradient and low gradient in the co-op trial.
Yep,
that's
perfect.
my thought.
Any questions from Chinese friends?
Yes. The result is perfect and very challenging case. And the finalist grading is less than 6, so it's lucky. So my question is, if the grading is more, which is how can we balance? If you prefer the gradings or the MR, which you consider first?
So what is the question? Say it one more time.
How we can balance the MR grading or MR degree?
Yeah, so that's a very a great topic. So in my sense, I prioritize MR reduction rather than the mitral stenosis, and in particular, probably the cutoff point of the mitral stenosis generally 5, but it depends on the patient. But I sometimes accept the 6 or 7 in some patient because a 91-year-old lady doesn't run anymore.
Do you have any questions? No, it's okay. So Shinsuke, you may have some questions.
Yeah. So we already analyzed the impact of the baseline mitral valve area in our Ocean Mitral Registry, and actually the 30% of the patient had a mitral valve area less than 4 in our registry, and also the 9% of the patient is less than 3.5. So, but interestingly, the acute procedure success rate and the 1-year clinical outcome is similar. Yeah, it's a very good information for us.
That's right.
And also, we always struggle with this problem.
Yeah, probably our population with a small body size have a different impact to the outcome compared to the patient with Europe and the United States.
And Tara, there's a question here from the audience.
Yes, please.
The question is about leaflet mobility and excursion in a patient with small valve area. How do you take that into consideration when positioning your device?
Yep. So maybe Mac, could you please comment on that?
The position of the device?
So the leaflet mobility and an excursion, how does that influence the position of your device?
That's right. So that usually I tend to assess the leaflet motion on the LVO tubule. It's a good motion or bad motion. And also the residual mitral valve area, it really depends on the mobility of the residual mitral leaflet. So if you clip on the target site, and if you have a significant stenosis, you can avoid the max side, or you can go to the calcified leaflet side and leave the more healthier leaflets, probably resulting in the less gradient.
Yep. I think that this kind of small body size is quite relevant topic to our Asian cohort. And we also need to check the mitral valve area. We also need to check the MAC or calcification or leaflet mobility. It's quite multifactorial, so it's all about the patient. So we need to look at each patient. Thank you very much, Mike, for your fantastic lecture.
Thank you.
Okay, so I would like to introduce the last speaker, Dr. Yeonjun Chen. Hopefully my pronunciation is okay for you.
So, hello everyone. It's my honor to be here to introduce a case, a TEER for a patient with Dextrocardia and functional mitral oxygenation. I have no any declare. This is the patient. It's a 72 years old female patient. He has hyperlipidemia without a severe coronary artery disease. But he has the persistent atrial fibrillation for many years. From the ECG, we can find the F wave nearly disappeared. So in our opinion, we have no plan to do the ablation for the patient because he had severe dyspnea. The TE found the patient had the 3+ MR and a little lower LVEF and greater enlarged AAD, but the LVD is normal. So from this, we can find the patient with the severe AFMR the patient was diagnosed. Especially the patient has the Dextrocardia, it's difficult for us to perform the operation. From the TEER, we can find the enlarged mitral annulus, and the reflex is central reflex. The AML is 24 millimeter, and the PML is about 10 millimeter. So from the 3D view, we can find the reflex is from the central area. So because the patient is the Dextrocardia, so we can find the view echo is about 120. It's different from the normal view angle. This is the first step for the MitraClip TEER. So we can find the first. This step is also our first strategy step. So we can find it. We use the normal. We use the normal shaping of the needle, and we have no tendon. So we make the more bending. The tendon is also can be observed. So it's difficult to finish the puncture. So we make the needle straight, and we can find the tendon is obvious. So they finish the puncture. So we can find this puncture is different from the normal heart on the left. So after the finish the puncture, we can find the puncture position is about 9 o'clock. It's similar to the 3 o'clock if the patient heart is on the left. So the place is very well. After the puncture, we think what clip should we choose and the plan. First time we use the CDS and SGC blue to blue alignment, and we can find we use the P knob to replace the M knob. Because we emulate the knob, we can find the M knob can make the clips move the lateral. So the M knob cannot be used for this patient. So we use the P knob to replace the M knob. And because if we use the K knob, the clip will move the front. So we must use the guide counterclocks to offset the front to make the clip back, move back. And we can find the clip move medially and have the aorta hug. And then we try many kind of methods. We cannot resolve the aorta hug, but we still want to have a try to grasp the lips. And in this situation, we sent the CDS into the left ventricle. We in this situation to grasp the lips, but we can find we can not well grasping the lips. So this plan cannot be finished the operation. So we should change the plan. First change is to how to resolve the aortic hug, and the next one is should maybe XTR may be better for grasping. So this is the second time. The second time try. We can find we use the CDS 90 degree clockwise insertion replace the blue to blue alignment. So we can find then we still use the P knob to replace the M knob because we know M knob is no use for this patient. We can find if you use the P knob, we can find the clip moved medially is similar to the M node if the patient is on the left side is similar. So the P node is similar to the M node. But still, the aortic arc is still can be found. So offset the P node. So we should use the guide counterclockwise to offset the P node to make the clips move ahead. So we still, because the P node cannot make the clip move to medial satisfactorily, so we should still use the plus node to make the clip move to the A2 and P2 earlier. But if you use the plus node, we can find the clip moved anterior and medially. So we must offset the anterior. So we should reduce the plus node, and then the P node is 1/2 circle and 30 and 60 degree plus can be found. The shape is very good for the operation. This is the grasping of the two leaves, and we can find is satisfied. And after finish the operation, the calcination is disappeared. So the MPG is about 3 reflex of the pulmonary vein is become normal. So from this patient, we can find the clipping in the Dextrocardia is a challenging case, but it is very it has the education meaning. Reverse bending of the transseptal puncture needle should be useful for this patient's puncture. It's very important for this patient. And new patient is feasible for the patient with Dextrocardia. Maybe it's useful for the patient if you have met this kind of case. CDS 90 degree crosswise insertion is very important for this patient to replace the blue to blue alignment. And the P node replacing the M node is also very important for this patient. Aortic arc can be well solved by the guide counterclockwise rotation and plus node and P node. So we can use this node can well resolve the aortic arc. So we should better understanding the anatomy and close operation with echo team is very important for this successful case. Thank you very much.
So thank you very much, Dr. Chen, for a fantastic case.
Great, congratulations. It's really interesting. So I have never done a Dextrocardia case, but the miskey in steering is exactly the opposite of off-label tricuspid. So, right, because the tricuspid, it's counterclockwise and A knob, and you go clockwise miskey and P knob.
Yeah.
And so it's actually really interesting. It's just the opposite, and it makes sense because you're going posterior. So it really makes sense.
So
great.
we must use many kind of knob to offset the different changes.
You figured it out really well. Panel?
Yes, it's a very challenging case and very interesting. I also have no experience about that. May I ask, I have a question. Do you think 3D printings will be more helpful?
Yeah, I think it's important because I have no experience about this kind of patient. So we also imitate the operation before we perform the operation. We use the MitraClip model to imitate the operation. We can find the M node is no use for this patient. So we So we give up the M noble, so use the P noble to replace the M noble.
Thank you.
Yes, so I have one experience of the Dextrocardia. But my patient is very special because the patient has a common atrial ventricular valve regurgitation. So the single atrial or single ventricle, so we don't need to do a transseptal puncture. But very complex, so we did the simulation using the 3D printed model. And based on the simulation, we inserted the CDS as 180 degrees MISCI. And in the contrast seat is the IVC is the left side. So we punctured the left femoral vein, and we inserted the guide and the CDS, but it is difficult to understand how clip moved by using the knob. So we switched to the TE image to the 3D MPR. And we checked how the knob can be used to clip the medial lateral and anterior posterior. So I think that in your case, using the 3D MPR is a very useful option to understand how clip moved by the knob. Yeah.
Yeah, I agree with you.
Yeah, definitely. I think that the preparation is quite important, and you also use the 3D printer model.
Yeah. It's very important.
You predicted how the nerve works well in this particular case, and you also fine-tuned the motion of the clip using the echo model during the procedure.
Yes, I agree with you, but I want to say, although we use the model to train, but we can find the training is different from the view on the echo.
Yep. Okay.
So it's different.
Okay.
So we must change the plan when the operation.
Okay, but we should prepare very much before, but however, we need to fine-tune our procedure during the procedure. So I would like to congratulate on your great case. Thank you very much for your presentation.
Okay, thank you.
Okay, so time to close the session. Thank you very much for attending this session. Today we learned a lot about the Asian experience of the MitraClip TEER, and Masa presented ocean data, and Dr. Shi presented the no X-ray procedure that emphasized on the importance of the echocardiographer. And Mike demonstrated the case with small anatomy, and Dr. Chen presented Dextrocardia. We really learned a lot. And I hope that this session will be very fruitful for your daily practice. I thank all the speakers and my co-chair, Paul, and also would like to thank all the teaching panelists. And last but not least, I thank the Abbott to sponsor and to help us to make it happen. Thank you so much for attending this session.